Um, it's my first time in the Philippines. I'm a medical oncologist. I'm the assistant director of the Cancer Center of the Medical City in Pasig. And I arrived this morning, and I'm so glad to be here. And I'd like to thank Guam Cancer Center for the invitation. I just wanted to ask everyone in the audience, who among you watches Game of Thrones?
Me and sister. Sister, raise your hand, sister.
I think this.
No?
Yeah, sister wouldn't like it because it's a little bit violent.
Yeah, no, not good for you, sister. Not good.
But there's a famous line from that show. It says, "All men must die." Remember?
Yep, I remember that one.
It's like because practically everyone there dies.
Yeah.
And in the old days, they would die of violent deaths. No? And nowadays, can I have the first slide, please? We still all have to die, and I think all of us want to die asleep. And if possible, without suffering. But sadly, the statistics say all over the world that people die most commonly of cardiovascular diseases, especially if you are a woman. And I was a bit surprised at that. And then the next most common cause of death all over the world would be cancer. And then diseases of the respiratory system, non-natural causes of death, and then other causes of death. So as you have been seeing over and over this morning, cancer is really very common, and unfortunately, it's a fatal disease many times unless you catch it early. So here we go. Next slide, please. So the question is, why do people die of cancer, and why is it such a difficult illness to treat? And there's a famous doctor, his name is Dr. Weinberg, and in the year 2000, in a journal entitled The Cell, or just Cell, he came up with a publication, and this very famous drawing, which you will see in many, many conventions, in international and local conventions. It's entitled The Acquired Capabilities of Cancer. And this is what differentiates a cancer cell from a normal cell. This is what makes a cancer cell deadly. A cancer cell, through genetics and through mutation, is able to, number one, it becomes self-sufficient in its growth signals. In other words, it's able to produce its own growth signals so that it just continues growing and growing. It becomes insensitive to anti-growth signals, so that whereas in normal cells, there's a point wherein the body is able to tell the cells, stop dividing, we have enough of you. Cancer cells are insensitive to anti-growth signals. The cancer cell is capable of invading tissues and is able to metastasize. Normal cells cannot do that. It has limitless replicative potential. Again, it just goes on and on like the Energizer bunny. It has sustained angiogenesis. In other words, it's capable of making its own blood cells, or it's making its own highways for food so that it can sustain its own growth, and it's able to evade what's known as natural death or apoptosis. So this is what makes a cancer cell, and what makes it so difficult to cure. Next slide, please. If we cannot cure it, can we at least prevent it? So over there on the left, you're going to see the preventable causes of death. You will not see cancer in the preventable causes of death. However, what you're going to see are risk factors or behaviors that can actually lead to cancer. So indirectly, if you are able to avoid, for example, tobacco smoking, and so therefore you have a lower risk for lung cancer. If you are able to avoid being overweight and obese, lessening your risk, for example, for breast cancer. If you are able to avoid alcohol and avoid liver disease and eventually maybe liver cancer. If you're able to avoid infectious diseases like HIV, which are also prognostic or risk factors for certain kinds of cancers. If you are able to avoid sexually transmitted diseases and if, drug abuse. So these are the preventable causes of death and also are somehow also associated with cancer, and so therefore if you avoid them, you might be able to avoid having cancer and dying from cancer. So the short of it is, all you have to do is embrace a healthy lifestyle, and you should know that smoking causes lung, head and neck, bladder, and other cancers. You've heard this morning. Obesity is associated with breast cancer. Alcoholic intake can lead to cirrhosis and hepatocellular cancer. Hepatitis B and C lead to liver cancer, while HPV Viral infection can also lead to cervical cancer. HIV and AIDS is associated with such cancers as lymphoma and leukemia. The other thing that we like to advise our patients, especially not just patients, but everyone normal and healthy, is to eat 5 helpings of fruits and vegetables a day and to exercise for 20 to 30 minutes 3 times a week. Next slide, please. Again, if you cannot prevent having cancer, it's bad enough you have it, but do you have to die from it? Can death from cancer be prevented? Yes, if you catch them in the precancerous or very early cancerous stage, you can be cured and not die from cancer. If you undergo screening, you can be cured of your early stage of cancer because almost all cancers, when caught early and are still surgically removable, are cured. Sadly, many cancers are detected at the late stage when cure is difficult, expensive, if not impossible. Also, many cancers produce symptoms only when they are in the advanced stage. And this is a sad fact. But fortunately, the 5 most common causes of cancer death in the Philippines, and I guess also here in Guam, are screenable. Next slide. So which cancers are screenable? And this was already very aptly discussed by our previous speaker. By definition, a screenable cancer is one that can be treated or cured if detected early by a screening test before there are any signs and symptoms of the disease. So it is the normal people, hopefully all of us here without any signs and symptoms, that are really the subject of screening tests. If you already have a sign or a symptom and you undergo a test, that's no longer considered screening. So normal populations of healthy individuals without signs and symptoms are the ones who undergo screening tests. The screening test must be reliable with minimal false positives and false negative results and must be easy to do and not unpleasant or harmful and must be cost effective because screening programs apply to populations of healthy individuals, not to individual or small groups of patients. Screening is done on healthy and asymptomatic, again, individuals who, by virtue of their age, for example, if you are 50 years old or older, you need a colonoscopy or your mammography, or by other characteristics, for example, if you are a smoker, you have been smoking 10-pack years or 20-pack years, and are at a higher risk for developing such cancer. So specific populations, by virtue of age or certain habits, are the ones who undergo screening tests. Next slide. So I'll just go very briefly through these next slides because this, as mentioned by Dr. Cote earlier, have been discussed by many of the other speakers. Screenable cancer number 1, breast cancer. So these are the screenable cancers. Screening test, self-breast exam or breast exam by trained health worker every year. Mammogram yearly for the first 2 to 3 years and then every 2 years. And what population is at risk? All women between the age of 50 to 70, younger if you have a strong family history, 10 years before the age of the youngest family member with breast cancer. Next slide. Screenable cancer number 2, colon cancer. The screening tests include fecal occult blood test, colonoscopy every 5 years, and stool DNA is just emerging as a potential screening tool but is not yet well established. Population at risk, adults 50 to 70 years old, 40 to 45 years old if with a strong family history of colorectal cancer. Next slide, please. Screenable cancer number 3 is cervical cancer, quite common everywhere, especially in the Philippines. Screening test is acetic acid wash. This is really not used, this is more used in the poorer countries like my country, wherein you have to go to the provinces, and what they do is they apply something that is like vinegar on the cervix of the woman, and the one that lights up becomes white. The same way when you drink vinegar, your lips become white. So there are certain areas that might manifest as white, meaning these are dysplastic areas, and these are the areas that are biopsied by your gynecologist. Pap smear continues to be the standard screening test for cervical cancer. What population is at risk? All women between the age of 25 to 60 years old, especially if sexually active. The details were more in the previous speaker's slides, and this is done every 3 to 5 years. Next slide, please. Screenable cancer number 4, head and neck cancer. Both the Philippines and Guam really has a very high incidence of head and neck cancer, so we see a lot of patients. And Screening test is physical exam of the head and neck and dental exam. Very easy, just do it every 6 months. Population at risk, adults with a strong family of history of head and neck cancer, smokers, and betel nut chewers. Next slide, please. Screenable cancer number 5, skin cancer. We do annual physical exam for this. You cannot see your back, so you have to ask your partner to look at your back or areas that you cannot see, to ask them if they have moles that seem to change in size, in color, or if these moles start bleeding, then these are questionable lesions and you might want to show them to your dermatologist or your oncologist. The population at risk would be the ones who are exposed excessively to the sun and those who are fair or are Caucasian in skin. So in my country and here, probably we're not going to see a lot of skin cancers. Next slide. So I skipped number 6. Notice number 5 was skin. Number 6 was prostate cancer. I removed that because before, we were advised to do a PSA. Nowadays, it's quite controversial because there's really no study that showed proof that overall survival of men who underwent screening and developed breast cancer lasted longer than those who did not go screening at all. So, it helps in early detection, as was mentioned earlier, so that is still a consideration. But I removed it from the list of screenable cancers. Screenable cancer number 7 is lung cancer in smokers. The screening test is low-dose CT scan of the chest without contrast. It's very easy. It's 30 minutes. It doesn't have to be the very thin slices, but it has to be read by an expert radiologist. The population at risk would be chronic smokers with at least 30 pack years smoking history and are still smoking or have stopped within the past 15 years because the risk for lung cancer in smokers remains for several years, 10 to 20 years after they stop smoking. Next slide, please. Number 8 is really more, again, for the Philippines because we do see a lot of hepatocellular carcinomas. So liver cancer is another screenable cancer. We do the blood test, alpha-fetoprotein, and we also do upper abdominal ultrasound. And the population at risk would be those who have been identified to have the hepatitis B and C virus, and those patients who are cirrhotics, and mostly these are the alcoholics. Next slide, please. So sometimes in the clinics, we are asked, why do we have to go through such, like some women consider mammographies as painful, colonoscopies, nobody wants to undergo that. Pap smear, women certainly don't enjoy that. So why can't simple blood or urine tests for tumor markers serve as screening tools for cancer? So many patients ask us about this, and maybe this is one of the things that make screening less popular than it should be. These are the answers. Tumor markers are not sensitive and may have many false negative results. Imagine if a test told you that you did not have cancer, but in fact you did. And I have stories of some women who actually could palpate the breast mass, but were afraid to undergo a biopsy and were afraid to go to a doctor, and they see in the newspaper this advertisement for a blood test that could detect if they have cancer, and it turns out to be negative, the test. So they tell themselves, good, I don't have cancer, I don't need to show this mass to a doctor. And this woman, and it's a real patient who went to me, actually was found out eventually to have cancer. That mass in her breast was cancer, even if the blood test tumor marker which was used for screening was negative. So these tests are not sensitive. Neither are they specific, and they have many false positive results. Imagine the reverse. If a test told you you had cancer, but in fact you did not. Many people are afraid of cancer, and I guess it's only human to be afraid of getting sick. And so if you have a very best friend or a recent family member who passed away from cancer, you certainly are concerned if you have cancer. So you go again to this clinic, the standalone clinic that says they have tumor markers that can tell you if you have cancer or not. And what if you took the blood and it was slightly elevated, and they don't have anyone in that clinic who could explain to you what the meaning of a slightly elevated CA125 is? Does that mean you have ovarian cancer? Does that mean you just have a cyst that's maybe inflamed? or an elevated CEA, does that mean you have colonic cancer? So sometimes we generally recommend for us not to do any screening, even the standard screening tests, unless it has been advised or unless you can show or discuss your results with a physician, an expert physician. So even the use of PSA, a sensitive and specific test for prostate cancer, is not reliable as a screening test alone, and results should be interpreted with a digital rectal exam. So these are the reasons why a simple blood or urine test, as of this day and age, cannot serve as a screening test for cancer. Next slide. So let's go to the more practical aspect of screening. How much does it cost to undergo screening and subsequent treatment of early cancer? So this is prices that I got from my hospital. It can be a very wide range, but so these are just used for example purposes. Let's look at breast cancer. The screening test is a mammography. It can cost 2,500 pesos. What is the treatment? If they find out that you have a malignant or what looks like to be a malignant lesion, you undergo wide excision, that can cost up to 50,000. And then, hopefully, you are cured. Same is true for cervix. If your pap smear is done and that costs around 1,400 pesos, you have it removed, the questionable lesion. This is really way high, 250,000, because that's total hysterectomy and bilateral salpingo-operectomy. But you are cured. For colon and rectum, you undergo a fecal occult blood test, which is 300 pesos, colonoscopy, which is probably 5,000 to 7,000 pesos, wide excision of that polyp, just have it removed, 25,000 pesos. You're cured. For liver, AFP, biopsy, 4,000, wide excision, 250,000, lung, low-dose CT, 5,000 or 10,000, and wide excision, 150,000. Cure, 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 cure. Can we go to the next slide, please? Compare and contrast that to how much it costs to treat cancer in the advanced stage. If you get, for example, breast cancer, you undergo the biopsy when it's already advanced. You undergo surgery, followed by chemotherapy, followed by radiation. Cost is 650,000 to 1.1 million. If it's stage 4, palliation is the goal, not cure. Cancers in the advanced stage, but this is not in all cases, so don't be afraid, but in general, stage 4 cancers are much more difficult to cure, and the goal becomes palliation. So what if it were cervical? Instead of the few thousand that you had to spend for a pap smear, you end up spending 550,000. For colon and rectal cancer, you end up spending 1.8 million. For liver, 450,000, if at all, and for lung, 300 to 600,000. Look at the goal of treatment. Cure is not your goal of treatment for advanced cancer, it is palliation, or extension of life, or making your life more comfortable. Next slide, please. So in one slide, you're going to see here the difference not just in cost, but in what you're able to achieve. So like, we want to say that the life you save could be your own when you undergo screening. I'm sure you've heard of this, and it is true. And I know it's not that simple, and I'm not simplifying things, and I'm not saying that this is certainly the way to go, but although that's what I believe, no, and we're trying to convince all our HMOs to pay for the cost of screening so that they don't have to pay for the cost of treatment. So they can save lives, more importantly, and not just have palliative care for these patients. So I think that's one thing that, again, we need to be able to educate the general population. When you undergo screening, the life you save could be your own. Next slide, please. So remember, screening, I said, was done on patients who are normal. So sometimes you already have symptoms, very early symptoms, and you're not aware that these are already symptoms of cancer. So aside from screening, early detection can also save lives. Next slide, please. These are the top 10 signs and accompanying symptoms of cancer. A sore that does not heal, has changed color, ulcerates, or bleeds. Unusual bleeding or discharge from any opening in the body. Earlier in the breast, you saw there was a bloody nipple discharge. Blood in the urine, stool, or frequent or heavy menstruation, especially in someone who's already menopausal and starts bleeding. That could be endometrial CA. A lump or a swelling that has progressively enlarged, with may or may not be associated with pain. Next slide. indigestion or difficulty in swallowing, change in bowel or bladder habits consistently for a duration of 2 to 3 months, obvious change in size or texture in a wart or mole, non-smokers' cough or hoarseness of voice that persists for more than 2 weeks, and in smokers' cough that becomes more intense. Next slide, please. Unexplained tiredness and or weight loss of 10% or more within a period of 3 to 6 months, persistent pain or discomfort in the abdomen, or unexplained fever, also known as fever of unknown origin. So please remember, just because you have any one of these, don't panic. Just maybe go to your doctor and discuss what you can do to find out whether or not this is actually a sign of cancer. Next slide, please. Sometimes we are asked, what is it that we want to be able to do for our patients at the medical city? So if you will pardon me, these are just slides that, that will allow me to explain what it is we are trying to achieve. So our goal for each cancer patient of the medical city is to have the longest possible life with the best quality of life, however he or she defines it. We all have different definitions for what a good life is, or even what a good death is, right? So we listen to our patients. We want to be able to guide you through the difficult course that every cancer patient has to go through. Next slide, please. So this is Mickey. I think you will agree she's quite pretty. She is our customer service chief, but she had cancer 2 years ago. And so we use her literally as our poster girl, but she's doing fine now. So we want to be able to do cancer care more customized and not, of course the NCCN guidelines are very useful, and I'm not saying they're not useful, but we go also beyond using the guidelines and look at what is unique in each patient, as was mentioned by Dr. Beheri. Each patient, even with the same stage, the same ERPR HER2 status, the same number of lymph nodes, and the same treatment, some of them will be cured of their cancer, others will not. And the difference lies sometimes in the molecular markers that is unique for each unique cancer patient. And this is what we are trying to do now as we advance towards more and more cure rates for our cancer patient. Next slide. So the lines in blue are our keywords. We consider our patients as partners, as I think even wherever you go, I think nowadays it's no longer the paternalistic kind of medicine. It's now more of personalized and partnership association or relationship between patient and doctor. We do have a multidisciplinary team approach, so we generally meet among all the doctors together with the patient as we do the roadmap, as was mentioned also by Dr. Beheri. We do innovative molecular technologies, and we do customized cancer care, which is probably the way to go all over the world. Next slide, please. Nearing the end, so the Medical Cancer Center, we can save lives, one patient partner at a time. So thank you very much for giving me a few minutes of your time, and I hope to see you again.
All right, thank you very much, ladies and gentlemen. One more time, Dr. Beatrice Tiangco.